How do patients present to us as breast specialists? And they're either symptomatic or they're not symptomatic, asymptomatic. And the asymptomatic pathway is very varied. And there's the National Breast Screening Program, which is one of the biggest referrers into a breast clinic. There are referred patients from employer-based health schemes who have their own mammogram and well women clinics. There are family history clinics, and there's the incidental discovery of lesion when some investigations are undertaken. For various other reasons, we are in the age of diagnostic CTs and MRI scans and things as such. And it's not infrequently that in a year we'll have about half a dozen cases or even 10, 15 cases of patients where a CT has been done for maybe colorectal cancer, and something's found on CT that suggests there may be a breast lesion, and they end up having investigations which prove to be malignant. We worked out that it's about 8% of our workload at the moment at the Princess Royal, CT detected lesions, and we published a paper to this effect. The symptomatic patients, obviously, you are our greatest referrers, and we have colleagues in other related specialities who would send patients to us. And then there is the woman who's got a fear of breast cancer, who's not actually symptomatic, but has a perceived risk or fear about developing breast cancer. So what is important? What is suggestive of breast cancer and what isn't? Is it easy to differentiate between these two groups of patients? Broadly speaking, yes. I think the symptoms quite often suggest a problem that needs to be referred urgently or not urgently. And if you look at benign breast disease, then you often see that these patients have got cyclical breast pain. They have cyclical nodularity, which means that there is nodularity just prior to a period, and this may then diminish or get better, improve after they've had a period. And you've got patients with a similar pathology of benign breast change which presents as bilateral nipple duct discharge. And this, when you have multiple ducts or bilateral discharge of a non-bloodstained nature, it's never a worry. Even if you were to phone me and ask me, I'd say, I don't think they warrant referral. Increase in the size of the breast in the absence of a lump in the breast or any other suspicious changes, virtually never do you ever find breast cancer. And long-standing nipple inversion, which how recent is a recent nipple inversion? I would say 1 or 2 years, but anything longer than that, you need to be a bit circumspect about it. If there isn't a mass in the breast and they've had a nipple inversion for 4 or 5 years, it's benign. It's likely to be benign. However, if somebody presents with a lump, usually in the slightly older women and in the teenagers, you can reassure them that it's benign. Current guidelines do suggest that they should be referred if anyone with a lump at any age. The risk is higher as the patient is older, and there is a 10-fold increase in risk in every decade. So if a 25-year-old presents, the risk is probably 1 in a million, and it'll be 10 times more in a 35-year-old compared to the 25-year-old. Skin dimpling, especially in the presence of a lump, is characteristic of breast cancer. It's like preaching to the converted. I know you all know this, but this is my remit. You've asked for it, so I'm going to tell it as I see it. Okay, so do bear with me. As I said to you, nipple retraction of recent onset, nipple deviation is something that is less appreciated in practice, and this is more apparent when you get the patients to raise their arms over their head. I don't know how many of you would do that when you see a patient. It is a routine practice that you examine them with their arms by their side and then the arms elevated over their head. You tend to find that if you do that, the nipple will deviate towards the axilla. That is a sign of a malignancy in the outer part of the breast, which tethers the ducts and hence draws the nipple out. And it is something that is valuable to do in your practice. Ulceration usually is malignant, but you do get benign. I don't think one should ever just deem it to be benign. Even if it looks benign, please refer, because you may find that you missed the boat otherwise. Blood-stained nipple discharge. I think most people will feel that blood-stained nipple discharge equals to breast cancer. And that's a little bit of a misconception, because the commonest reasons for blood-stained nipple discharge is either ductectasia or fibrocystic disease and the intraduct papillomas. However, because some of them may have DCIS or intraductal cancer, we do recommend that you refer them to us, because they do need a workup. We do need to exclude DCIS. Most often we find that it's not breast cancer, it's something else. Okay? An axillary lymph node, as you know, there are a number of reasons for lymph node enlargement, but again, you can get occult primaries in the breast, which are difficult to even find on mammograms or on clinical examination, and they're present with an isolated axillary lymph node or ipsilateral axillary lymph node enlargement. So they're rare, they're not common, but we do come across them, not too infrequently. And inflammation of the breast that does not respond to antibiotics. I think there is this worry that, and I think the population, at least where I work, are very, very well educated, and maybe to my detriment, because they come and challenge me about anything, any kind of reassuring sentences. If I try to reassure them that this is inflammation, they will challenge me saying, how do you know? Because they've read about inflammatory breast cancer, and the internet can be a useful tool, but I find it a bit of a headache personally. I'm sure you all agree, you've probably had that. And I sometimes get people printing off stuff and bringing it to a consultation. And then when I say, this looks like an abscess, they'll take it out and say, look, there are cases that have been missed because they were treated as abscesses. So, hey, if it does not respond to, there's a difference. The breast that is actually inflamed due to infection is exquisitely tender, whereas inflammatory breast cancer may not be, usually isn't. And if there is you find that the breast is not very tender, but it's red and it's got pitting, peau d'orange, then it's likely to be inflammatory cancer, especially if there is a big mass underneath, or even a small mass. So I would suggest that you refer urgently. If it's a very, very tender breast, red, then you're perfectly within your rights to treat it with antibiotics for a week. If it doesn't respond, then you can obviously refer them on, and you haven't done any harm by treating them in your surgery for 1 week. Change in the texture of the breast. I've put this down, it's kind of something that I sit down and think that I know my trainees, and when I vet what they see, they have a perception that every patient that's referred has to have something wrong. And even if it's normal, it takes many years. Stephen is one of my colleagues from Mayday, and he will probably agree. It takes many, many years to actually be able to tell the difference between thickening, which is normal. It's just normal breast tissue that appears thickening. The breast isn't homogeneous. It is heterogeneous. You find areas that are soft and areas that are hard. But it takes years of experience, so I wouldn't expect any, my juniors don't do it, so I don't expect anyone in primary care to say this texture change is benign, leave it alone. I think you should. This is because lobular cancer is one of the frequently missed diagnoses in breast cancer, and it presents as texture change. You might think that it is thickening of the breast. On the mammogram, you may not see it. On the ultrasound scan, you may see a part of it or none of it. And that is where there is the chance that this may be missed. So we do say that if you find that it's asymmetric, especially if it's on one side and not the other, in a postmenopausal woman, it's very important that you refer these. In a premenopausal woman, you can examine them in another phase in their menstrual period and check whether it's still present or not. What kind of, something that fluctuates, which is present one day and is not the other, is very unlikely to be due to breast cancer. Okay. Now, something about risk factors. I'm sure you'll all want to take this back, and I didn't put gender there because people think it's stating the obvious, but the relative risk compared to a male is that being a woman is your greatest risk for getting breast cancer, and that's 100 times, relative risk. Age is far greater than any of these. So as the highest incidence is in the 70 to 80-year-olds. And hence, I've been trying to say this to my colleagues everywhere in primary care, that please, if you have an opportunity to examine the woman, when she comes to you for other things, bear in mind that this age group, the 70 to 80-year-olds, especially because they don't often get invited for breast screening, they may have a cancer there which we could treat. And sadly, when we did a survey of locally advanced breast cancers that we couldn't quite help them in the way we would like to, we found that majority of them were over the age of 65, and most of them, 60% of them, were from care homes where nobody ever bothered examining their breast, and it's only when it ulcerated that they came to see us. Oops, I'll go back one. And these are not written in stone, but they give you an idea as to a woman's risk. This especially does, it's 4 to 5 for atypical ductal cells. If you've got atypical lobular cells, it rises to 7 to 8 times the average woman for that age group. HRT is only 1.35. And I'm sure it's not, I didn't put that down because I have gynecologists following me. But I'm sure John Arian and Laila know my views on that. We've shared this several times in the past. And family history, where there isn't a genetic link, is about 2 to 2.5 times the average. I did think I'd put this slide to show age-related age and incidence of breast cancer and relating to age. And if you look at that per 100,000 population, 25-year-old, 1.2. So it's about 12 per million, right? And as you go down that, sorry, this slide doesn't project well, it kind of doubles. If you look at it, it's about 10 times. Yeah. Every decade, it's about 10 times. So as a simple rule of thumb, 20 to 30-year-olds compared to 30 to 40-year-olds, they got 10 times less risk of getting breast cancer. So the highest incidence is in this group. Yeah. 85 and over, invariably. Some, you might think, did I hear this somewhere else? The similarities are with the prostate cancer, where they say after the ages of 75, 80, almost everybody's got prostate cancer. Some of it is not going to kill, some of it's going to progress, right? So I suspect that a lot of women beyond the ages of 85 may develop cancer, but some of them may never discover it and die a natural death. Forgive me for this. I did not seek to offend anybody in the audience, but I did allude to it earlier, and I do think that it is important that the schema of examination be followed, because unless you elevate the arms above, you will not see the dimpling and you will not see the nipple deviation, and sometimes you'll even miss the obvious thing. The other danger area is infrequently you find that the tumor is tucked underneath in the inframammary crease, and it's not till you elevate the breast and look at it that you will. The last, about 5 years ago, I gave this same thing, presented the same thing, and somebody went and look, this was to an open evening where women, not GPs, were invited, and one of the women in that audience found something in the 6 o'clock position, and it was cancer. So I was very happy. So I just made it a ritual that every talk I give, I will talk about this. Family history and risk is something that, this wasn't my remit. It was about referral pathways, but I think in a way it is. This is just about telling you what the risks are. At these, under the age of 50, if you've got any relative, as I said, it's about 2.2. If that relative was over the age of 50, it's about 1.6. So not very high. But as you go down, this is first degree relative with bilateral breast cancer, 2 first-degree relatives, and this is a second-degree relative. So there is no effect at all. So aunts, great aunts, grandmothers don't count. So what happens with a genetic mutation? How are these families affected? If the woman's got a BRCA1 mutation, by the age of 70, she's got a 70% risk of developing breast cancer, ovarian cancer 46%. The male is not exempt from this, and 6% of males will get breast cancer, so it's important to include them if you've got a BRCA1 mutation family. Or if you've got a BRCA2 gene carrier, then the risk of prostate cancer rises quite significantly, and you should counsel them or refer them to a genetics center. And currently, the referral pathway for people with history of breast cancer is to a family history clinic. Now, it is very important to distinguish between a patient with symptoms and no symptoms. The ones with symptoms need urgent assessment. That is the 2-week wait, as you know it. Sometimes I hear from my patients that my primary care colleague has said to them, "Oh, go to the NHS and they have to see you within 2 weeks. In private care, you may not be seen that quickly." And I think that's a misconception. I think in primary care, in all these hospitals that have been talked about earlier, mentioned by Ewan, they all have one-stop breast clinics, and they would see patients within 2 weeks. Whether it's primary or secondary care, you have to see them within 2 weeks. Okay. So the BRCA mutations, the family histories should go to a family history clinic. That family history clinic may be within a hospital setting. Some places like Southeast London, especially I think in the Camberwell area, they've got risk assessment clinics in primary care. Hopefully, we will have sufficient confidence in the future to develop this in primary care and reduce the amount of patients being referred to secondary care. That assessment takes place there. If they're perceived to have a moderately high risk, then they have mammograms every year. If they are high risk, then they get referred to the genetics unit where they undergo testing for a BRCA mutation. This breast cancer related gene is an oncosuppressor gene. It suppresses the development of breast cancer. We all have it. However, in affected individuals, and this must be an environmental influence that brings about this change. It's usually those who understand genetics, it's either a transitional change, or it's a deletion of one particular amino acid, which results in a different type of gene, which is less functional, and therefore that risk, that shield you've got of protection is lifted, and then the environmental influences can act on the breast tissue and cause cancer. You have got a protective shield, which is the BRCA genes and other genes yet undiscovered. So, urgent referral. There is a book called, I think it's called Current Guidelines regarding best practice in referring patients with symptoms to a breast clinic. We will send you a link, electronic link. There's far too many pages to actually print it out. So Sam is going to send you all a link at the end of the day, or maybe in the next few days. I'm sure she's got better things to do this evening. But certainly next week you will expect, and you can open that link and you can either download it and save it on your computer, or you can print it and save it as a copy. It gives you guidelines, and these are based on evidence by colleagues, some of them who I work with. Okay. It suggests that under the age, 30 years and over, any discrete lump should be present, should be lumpiness, change in texture. Depends on who says it, you know. I just use the word lump or change in texture. Any of this, you need to refer urgently. At any age, and including males, these are signs of breast cancer, and therefore we don't have any age boundaries there. Okay, so anything that you're suspicious, and what you've got to understand is that there are only finite resources within the NHS, and you can only see so many patients in a day. And if you see patients that are inappropriately referred in the clinic, then the ones that deserve urgent attention may be disadvantaged. So with these things, you are empowered to make the decision as to how to refer the patient. And if it is spontaneous unilateral blood-stained discharge, if it's recent nipple retraction or distortion or nipple ulceration or an axillary lump, refer them urgently. Of course, in private care, we don't have any such restrictions as to who you can refer and you can't refer. But certainly for non-urgent referrals, the guidelines, and I didn't make them, but I certainly endorse them, is that breast pain can be managed in the absence of a discrete abnormality. Breast lump under the age of 25 without any suspicious features, you can refer them non-urgently. Because I talked to you about the incidence, it's 12 in a million for a 25-year-old, and it's half that under the age of 25. Nipple discharge, bilateral multiple ducts, we've been through all this, and family history, appropriate referral is not to a 2-week wait clinic, it is to a family history clinic. Now, I see referrals headed as family history. We are at the moment, struggling with trying to organize our services. I'm sorry, I'm going to be a bit scathing about the services, the kind of admin clerical supports we have. They do not sift out the letters, and therefore, if you say, I would like you to write to me telling me about this patient's risk, they get sent an appointment. And we have no control on that. We have to change that. We're not blaming you for it. We're blaming ourselves, and we have to change that. So I'm having a little bit of a moan, all right? And please, cosmetic referrals, they are the most challenging, the most testing consultations we ever have. Breast cancer, breast lumps, patient worried about cancer, they're very easy to deal with. These are probably the worst. They take the longest time. They're all after a freebie on the NHS, unfortunately. And you all know it, and we know it. You're pressurized into doing it, but they don't send them to the two-week wait clinic, please. Okay? So, referrals for routine screening mammograms. That's where I'm not quite finished yet, but this is my last slide. Please don't send referrals to a symptomatic clinic. The way this breast services work, you have a symptomatic patient, you send them to a breast clinic for assessment of the symptoms, and those are the two-week wait clinics. You have a patient with a family history and no symptoms, you send them to a family history clinic, which is non-urgent. You have a patient, a woman, it's not a patient, a woman who is of screening age and has missed a screening mammogram. You don't send that referral to the local breast clinic. They're not funded. They're not funded to do that. So if you lose out money as well, because you send them and they get assessed as a one-stop referral. And the chances are that they will be seen by somebody and they'll find a little bit of thickening, and they'll end up having an ultrasound scan and then something else, and in the end everything's fine. So if there are women with a perceived risk, the analogy is that you got someone with a family history of cardiac disease. You don't refer them to a cardiologist in the secondary care to assess and decide, do you? You manage them in primary care. Breast is the same. If you've got someone with no symptoms but a perceived risk, you can refer them to the family history clinic, but don't send them to a symptomatic clinic to be assessed, please. Okay? Now, the one thing I was going to say is that in the NHS, we've got very good teams, we've got clinics, and we've got a whole setup geared towards all kinds of for all kinds of illnesses, cancer services especially. There seems to be some misconception that these do not exist in private care. We are bound by the same guidelines, and we are sort of scrutinized in the same way that the NHS is to provide those services. So therefore, you will have one-stop clinics in private care. It is kind of unusual to have a breast clinic that's not a one-stop clinic. You will have at least 1, 2, 3. I think there are 4 at Chelsfield, 4 at Sloan. I'm sure there's similar 4 or 5 at Shirley Oaks and Blackheath. So there is that. The other thing about facilities, the facilities are the same. Teams, we've got a full complement of teams, breast care nurses, oncologists, and everybody. So there isn't. So let the patient make the choice. But importantly, it's important that the patient's needs are addressed, and they're addressed quickly. And they can be done through both pathways. Okay, thank you.